You are now listening to Nailed It, the Orthopaedic Surgery Podcast.
Dr. Tsai, welcome to the Nailed It Ortho Podcast. I am so happy that you've taken time out of your holidays to come and record this. So welcome to the podcast.
No, thank you for having me. I appreciate it.
Yeah, and we typically start off at the beginning with a couple of questions, just getting to know our guests before we jump into the topic of the day. And so, this is a foot and ankle topic. I know I've seen that you've done a couple of talks on foot and ankle, especially for the Foot and Ankle Society. So what brought you towards the specialty of foot and ankle? What made you want to go into it?
Yeah, so foot and ankle for me, what stood out was really the kind of diversity of the procedures out there. In my program, which was SUNY Downstate, we get exposed to foot and ankle on the early side, which is great. And so, I've had a chance to do other rotations such as sports, trauma, and I like them. But really, when I did foot and ankle, I was really impressed by the different procedures that I'd see on a typical basis. So, really a combination of aspects from all the different subspecialties, whether it's joint replacement, sports, reconstructions. And I just kind of liked how each day was so diverse and it kind of kept things interesting for me. And that combined with the fact that my mentor at my institution, Dr. Jaime Uribe, was simply put a great teacher and really kind of motivated me to pursuing this great subspecialty.
Yeah, it's awesome. I found, through talking with different people that being able to, do such diverse, a broad range of, injury, just like you were saying, from trauma to sports to reconstruction and to arthroplasty is a lot of things that draw people towards foot and ankle. I really enjoyed my foot and ankle rotation too. I liked it a lot.
Yeah.
And another question I have for you, which is more of a different question, is what is one of the books that you have gifted to others? And so this can be an orthopedic book, this can be a non-orthopedic book. We've had a lot of different guests say things. Some guests have given us different poem books that they've recommended. Some have given us orthopedic books. So what is one of the books that you have gifted to others?
That's a great question. So actually, it's interesting to bring that up because, it being right around the holidays, more recently, I've, had a chance to read or look through a book called There and Back, Photographs from the Edge by someone named Jimmy Chen. He's a photographer, he's a climber, he's an athlete, and it just has a bunch of great photos out there, beautiful shots from his adventures and from around the world. So it just, I thought it made a great holiday gift, and that's something I've been able to give out, this holiday season.
That's awesome. I will have to put that on my list of books to check out. I always take notes and write down what one of our guests say and try to check out some of those books. So definitely try to check that out. And last question here is, do you have any interests outside of the field of orthopedics? We know we all love orthopedics so much. It's great. But do you have any other interests or things that you like to do outside of the field of orthopedics?
Typically I like to stay active, my big sports and by no means am I an expert and great at it, but, I love skiing. And this time of year, I usually have a couple ski trips kind of lined up. Try to stay sane by, getting some kind of exercise in per day, usually kind of running or lifting, and just spending time with my wife. And we have a 2-year-old dog, actually, that keeps us
Nice.
active.
Yeah, that's awesome. I think I tried skiing for the first time this year, and going down the hill is cool. And then you start to pick up speed, and I realized I didn't really know how to stop. So
You don't have that, same fearless nature as, when you start out, when you're 4 or 5, when you're older and you have a lot more to lose with falling down, it becomes a little bit less fun to be kind of out of control.
Yeah, and you always hear about people tearing their ACLs and having pilon fractures from skiing. So that's in the back of my mind. But
well, at least you know where to go, right?
Exactly.
You can navigate that a little bit easier.
Well, cool. Well, let's go ahead and get into the topic of the day. We can switch gears and talk a little bit about Hallux Valgus. Some people refer to this as bunions.
Yeah.
And so Dr. Tsai, say for example, you have a 47-year-old female who just comes into your office with foot pain. She been told that she has a family history of bunions. She was told that she has a bunion and she should see a foot and ankle orthopedic surgeon. Can you kind of take us through a little bit? What are some of the like risk factors for having a bunion, what it is, and then we can kind of move forward and get into, kind of the physiology of how this happens.
Sure. So, it's no surprise that you find bunions more in societies where people wear shoes. So the environment certainly comes into play. Specifically, constrictive shoe wear, or what we call, fashionable shoes or high heels. Those definitely put someone at risk of developing a bunion. And whether it's because female patients are usually more likely to wear those type of shoes, or just some separate factor we may not be sure of, female patients are more likely to develop bunions as well. Also, the concept of hypermobility. So if a patient has hypermobility in their other joints, that makes them more likely to present or develop a bunion over time, and to certainly develop one earlier on in life.
Yeah, is a constrictive shoe wear just because it's just pressing up against the metatarsal head? Is that the main reason? Or I never understood why it was constrictive shoe wear, but is that just the main reason?
Yeah, I mean, I think when you're wearing something that kind of crowds the toe box and you're putting a lot of pressure, you could break down some of that medial capsule, and subsequently, have that first metatarsal start to drift into varus, which a lot of people have implicated as the kind of primary factor into developing bunion. So I think it's that pressure coming from all sides that sort of destabilizes the normal stability present at the first MTP joint.
Yeah, and that you just perfectly transitioned yourself into it. I was actually going to ask you kind of what's some of the pathophysiology behind this Hallux Valgus. Can you kind of walk us through? I know you're just saying, the metatarsal starts going a little bit of varus, but can you tell us a little bit more about how this, kind of how this progresses?
Yeah, sure. So I found this to be really cool, actually. When I was learning this, I thought it was learning about the pathophysiology here actually helped me kind of remember the anatomy, and to kind of keep it in mind, as opposed to the other way around where, you start with anatomy and go on to pathophysiology. So I like to think about it as this whole process starting with the medial capsule breaking down. Okay, so the medial capsule breaks down. What happens is that first metatarsal starts drifting into varus, or more specifically, the distal aspect of the first metatarsal starts deviating medially. And then the important thing to remember is kind of everything else stays in place. So the sesamoids stay in place, the tendons that cross the joint stay in place, and that in turn forces, and most of those actually attach onto the proximal phalanx. So what starts with a medial deviation of the first metatarsal, and leaving the other factors in place, it kind of forces or makes the deformity worsen over time. So the EHL will kind of bowstring the proximal phalanx, which in turn can force the joint more into valgus, which in turn forces the EHL to become even tighter. Subsequently, the proximal phalanx can also be pulled on by the adductor as well. And lastly, the sesamoids stay in place, and those are kind of a good marker for how bad a bunion deformity is.
Okay, sesamoids staying in place.
Yeah.
And so just like you're saying, just to recap, starts with the medial capsule, and then it, the distal aspect starts to go medial, but everything else stays in place, which bowstrings, which, you have your EHL and your flexors, bowstring lateral to the MTP, and that kind of extenuates this deformity. And so when you get these patients in your clinic and they come, they get a referral from their primary care physician, what are some of the things that you're asking them in the clinic? Like what do you go through when you speak to them?
Yeah, so I think it's really important to kind of note where they have pain, and really kind of get at what they're presenting to you for. Now, a lot of them will, be coming to you, practically speaking, for surgery, right? You're referred. They've been through everything before. They've been told they have bunion, and if you have a kind of busy surgical practice, a lot of them are just come to you after failing non-operative management. But what you're looking for primarily is someone that's has pain over the medial eminence. All right, so pain on the inside part or medial aspect of the first MTP joint. They'll say that they're kind of tender right over that area. They'll describe difficulty with shoe wear, and they say they're kind of fed up trying to find wider and wider shoes. And then, associated lesser toe deformities. So the concept of transfer metatarsalogia later on, with more severe Hallux Valgus, or developing lesser toe deformities, especially the second, such as a hammer toe, or in really bad cases, a crossover toe.
Okay. And do you find that, that a lot of patients will say like, oh yeah, my sister has it and my aunt, and we've all had bunions, and you find like there's a family, people always talk about some type of a family history, or do you haven't seen that as much?
No, it happens all the time. I mean, usually I'll say, they'll mention either their mother or their grandmother. They'll say, they watched their grandmother develop these or how bad her bunions were, and a lot of times they'll say, I don't want mine to reach that severity. So that's one reason that they're usually at that point at least willing to discuss treating it now, and the questions kind of revolve around that.
Okay. And so what are some of the things that you look for on a physical exam? I know me as a very novice intern would look and I'd see, it looks like a bunion. I'd say, okay, well, I mean, it's a bunion. I mean, what else do you want me to tell you? So what do you look for?
Yeah. So, I mean, I think the first thing, and this could be pretty straightforward, right? You want to quantify, and we'll go into kind of how we could do so objectively and with angles, but you can tell, I think most people can tell, even the layperson looking at a bunion, how bad is it, right? How big is that bump on the inside? How badly is that toe turning in? And as with anything with foot and ankle, you want to make sure you do this standing up. I've seen bunions look really bad, or I should say the other way around, look not that bad sitting down or non-weight bearing. And when they start to put weight on it, you'll find that toe kind of drift over a lot more. So, certainly a standing exam is very, very important. You want to look at the lesser toes as well, right? So as that bunion starts to get worse over time, it's going to cause that, the second toe and sometimes even the third toe to drift upwards. And in the case of the second toe, start to cross over, which can actually be for some patients, the main presenting kind of symptom. They may not be as bothered by the bad bunion that they have, but they do notice that second toe is kind of sticking up and interfering with shoe wear, because the top of the toe rubs on the top or the bottom part of their the top of their shoe. And you want to look at the degree of pronation of the hallux. So it's not a straight two-dimensional deformity. So what starts to happen as that hallux kind of gets worse is it starts to pronate, and so you'll notice the hallux basically kind of internally rotating, and they'll develop a callus kind of on the medial aspect of their hallux IP joint. So that, combined with other deformities more proximal, such as a flat foot, or perhaps a valgus deformity at the ankle joint, can be or should be taken into account.
Okay. So, just to reiterate, some of the important things you want to look for is you kind of just want to like quantify it. And we'll talk about some of the angles in a bit, but you want to see the pronation. If there is any pronation, look at the other toes, see if there's any crossover between the hallux and maybe the second toe, see if there's any other deformities going on. Look at the forefoot. You do this sitting and you also do this standing up. Now, when I read, I always hear about excessive TMT or tarsal metatarsal motion. How do you assess that?
Yeah, I found this to be kind of very difficult, and the truth is, it's not that difficult. But the difficulty in it is just knowing what's excessive motion and what's not, and this just comes with experience. And so, the best way to do it is, you have them kind of sitting down, and with one hand, you're kind of grasping the four metatarsal heads, the lesser metatarsal heads. And with the other hand, what you're doing, you're gripping kind of the dorsal and plantar aspect of the first MTP joint, and you just kind of do a little shuck test. You kind of raise it up and down, and one, you can compare it to the opposite side, but people that are hypermobile are usually hypermobile bilaterally. So you kind of get a sense for what feels hypermobile and what doesn't, based on doing a bunch of these exams and just getting a sense of what feels looser versus what feels more kind of normal. And so that comes with time.
Why does this matter when we're talking about hallux valgus, that they have excessive motion in that first tarsal metatarsal joint?
Hypermobility is classically an indication, in setting of a bunion, to do a specific type of a bunion procedure called a lapidus, which is a fusion of the first TMT joint. The thinking is that if you're hypermobile there, that's your driving force. You're hypermobile not only in the dorsal plantar plane, but also in the medial and lateral plane as well. So if you just do a distal osteotomy or a proximal osteotomy, you're not really treating what's the primary driving factor. And you may make the bunion look better, but they're at high risk for recurrence because of the instability present at the TMT joint.
Oh, okay. Okay, cool. Makes sense. So assess their motion, get them standing up and, do a complete neurophysical exam or neurovascular exam. So what imaging do you get, when they come to your clinic, what x-rays are you getting? If you're getting x-rays, or are you just looking at it clinically? And then once we go about kind of what x-rays you get, then we can talk about the different things that you look for in those x-rays.
Sure. So yeah, always get x-rays. And again, I stress the importance of weight-bearing x-rays. So I'll always get a 3 views, the AP view, the lateral view, and an oblique view can be helpful as well. And this is what really allows you to quantify your degree of hallux valgus, but it also allows you to kind of rule out other, factors that might drive what your decision-making will be. So, one example would be, the patient has significant, arthritis, either at the first MTP joint or further back at the midfoot, tarsal metatarsal joints. Those would certainly drive what procedure you ultimately may end up doing on the patient. And then, of course, you're looking at other things like lesser toe deformities, metatarsus adductus, and then, certainly the patient has a flat foot. It should be noted as well.
Right. And so what are, we're looking at an AP of the foot, we got those weight bearing films, and what do we look for? How do we assess this? And when we're trying to look through the eyes of, is this hallux valgus? And then we're trying to see how bad it is or how severe.
Yep. So I start with, when I look at these images, I just go first to the first MTP joint. Okay. And the first thing I'll notice, is this actually a bunion? A lot of times patients will present, they'll say, I have a bunion, and they'll point to a large bump on the top of their first MTP joint. And that ends up being, hallux rigidus with a dorsal osteophyte. To a lot of patients, a bump is the same thing. So I'll drift right there first and just see, do I have a incongruent joint where, the first MTP joint, is, or the first metatarsal head is uncovered. And then after that, if they do indeed have hallux valgus, I'll go ahead and I'll start to quantify it. Okay. And the main angles that we usually look at, or at least I look at, I start with the intermetatarsal angle, which really quantifies how deviated the first metatarsal is from the second. For me, this is the easiest one to kind of illustrate to the patient why they're having pain. I tell them, look, that bump on the inside is not because you're growing some more bone there, but it's because basically the first metatarsal is deviating from the second. It's forming a V when it should be parallel. And we quantify how bad it is by how wide the V is or how high the intermetatarsal angle is.
Okay. So that is the intermetatarsal angle. And so that angle, again, you just kind of get a line down the canals of the first and second metatarsal, and that is that angle. Do you look at any of the other angles, or can you kind of describe? And they always we always hear they talk about a HVA or the Hallux Valgus angle. Do you ever look at that?
Yeah. I mean, I can't say it's one I measure specifically, but
Okay.
that's one that's going to get higher as the bunion gets worse, right? So that's the angle. Use the same line down the axis of the first longitudinal axis of the first metatarsal, and then you draw a second line down the long axis of the proximal phalanx, and the angle that is between those two represents the Hallux Valgus angle. I think that kind of measures how uncovered your first metatarsal phalangeal joint is.
Okay. And then I've always read now more about like the DMMA angle. What is this? And, should we be paying attention to this, or like, what is the importance of that angle? And what is it? What does it stand for?
Yeah. The distal metatarsal metaxial angle, I think. But
Okay.
basically, it's a measure of how laterally deviated the joint surface is of the first metatarsal head. So this is very controversial. I think I think this is a big kind of measurement that was brought up a lot, and certainly I think it's tested and it should be well noted. But it allows us to quantify how laterally deviated the articular surface is relative to the long axis of the first metatarsal. And the reason this comes into play is with patients with really a high DMMA, where the joint surface is really kind of pointing laterally. A patient may demonstrate Hallux Valgus on clinical exam, but their joint will actually be congruent, meaning that if you kind of draw a line between the medial and lateral aspects of your joint for both the metatarsal head as well as the proximal phalanx, they'll be parallel in patients that have a high DMMA, and that's going to come into play later. If the patient really has this, if you do just one osteotomy, you can actually take a congruent joint and make it an incongruent joint. So it's just worth noting, if the patient really has a high DMMA, and this will usually be pretty obvious because they'll have a large bunion clinically. But their joint will just look curiously like it's not uncovered. It just looks, congruent.
Okay. That makes sense now. And so, we've had this patient, we've gotten them and we've gotten x-rays, and, now we're back in the room with them. What patients are you undergoing non-operative treatment with? And then what is your non-operative management? Like, what would you do to your patients?
Yeah, so it depends on their complaint. So if they are bothered primarily by the bunion, the medial eminence, one, I tell them, that if they have pain, sometimes they don't like the way it looks, but they don't have pain, and I just sort of kind of reassure them and tell them, if they don't have pain, there's not much they need to do other than maybe avoiding wearing tighter shoes to prevent it from getting worse. Which is something I actually tell all patients, even ones after surgery. But if they have pain at the medial eminence, at the bunion, I tell them, look, there's two solutions for this. You can either wear a wider shoe, which is essentially the non-operative treatment for a symptomatic bunion, or you kind of narrow the foot and narrowing the foot with surgery. If they have kind of lesser toe deformities, such as transfer metatarsalgia, or hammer toes, then you can employ things like a metatarsal pad, which offloads the metatarsal heads. You can utilize something called a boot splint, which can help with crossover or clawing of the second toe. Toe spacers can certainly, they're not changing the degree of varus present at the first metatarsal, but if the patient has issues with the hallux impinging on the second toe, a toe spacer can help prevent that, so that the two toes aren't kind of rubbing against each other.
Yeah, and when we mention, or when we say transfer metatarsalgia, we're pretty much just saying the pain that is now along the other toes of the foot and not just the hallux, correct?
Yeah, and actually it's mostly at the level of metatarsal head. So going back to deformities, what happens is as the first metatarsal drifts into more varus, the abductor again stays in place, and it kind of lifts it up, and so you're not engaging the windlass mechanism as well, and subsequently you're not bearing as much weight as one normally would with the first metatarsal head, which could be anywhere between 50 and 70%. And so that's get transferred over to the second. And when the lesser toes or lesser metatarsophalangeal joints get overloaded, they become destabilized and start to get a kind of a cock up or clawing, which is why you so often see with bad bunions that second toe demonstrating a transverse plane deformity, usually drifting in the varus, and that's why you get the crossover toe. So again, it's the kind of lifting up of the first metatarsal and the shift of the weight to the second MTP joint that leads to this phenomenon, known as transfer metatarsalgia.
Okay, cool. I appreciate you for explaining that.
Yeah.
So those are the patients that you're not operating on. So what patients? I know I guess there's different degrees of hallux valgus, but can we kind of go through the operative treatment of hallux valgus, and I guess we can break it down into like mild, moderate, and severe, and then kind of what falls into that category.
Sure. So, again, by the textbooks, a mild deformity, and again, I'm just going to refer to the intermetatarsal angle because that's the main one I use to kind of judge. But typically, a mild hallux valgus will kind of be with an intermetatarsal angle of less than 13 degrees. And again, I judge these both radiographically as well as clinically. So, in these cases, they'll be symptomatic over the medial eminence, but the toe itself won't look terrible. And so in these cases, you can often get away with a distal osteotomy. There's a lot of different osteotomies kind of described as distal osteotomies, but I think the most common one is called the chevron osteotomy, based on the shape of the osteotomy that's made. The reason it's so popular is because it works. It's a very stable osteotomy because of its shape, and it actually allows you to get quite decent correction and allow you to also, with certain modifications, address kind of biplanar deformities. For example, in the case of a increased DMMA with congruent joint, you can kind of add in a closing wedge osteotomy in order to correct for that increased DMMA.
Okay, so distal osteotomy for very mild hallux valgus, and then this chevron osteotomy. Can you describe? It's kind of just like you're cutting a V, I guess you could say, and just shifting it laterally. Is that correct?
Yeah. So the apex of the V is distal, and then you bring the limbs proximally, one in the dorsal direction and one in the plantar direction. Mm-hmm. Usually, in order to maintain some stability, the angle between the two is anywhere between 45 and 60 degrees. For the most part, you want to try avoiding making one limb more vertical because that can lead to more instability, right? The more acute the angle, the more stable it is. And, one technique tip is obviously you want to make sure that the plantar limb exits out proximal to the sesamoid. So you do not want to be kind of cutting into the metatarsal sesamoid articulation, because that can lead to, arthritis and pain plantarly.
Okay. So we'll do that distal osteotomy. And then with the since we're shifting the metatarsal head laterally, at least from what I've seen, you'll shift it laterally, and you may, hold it in place with a screw or whatever fixation, construct that you use. And then do you just shave off the extra bone since you shifted it laterally? Now there's a little piece of bone immediately. Do you just use a saw and shave that off?
Yeah. So I'll usually use one, and typically you can, depending on the patient and the quality of bone, I typically use one, 3-5 millimeter screw. You can throw that screw depending on how long you make each limb. You could throw it from proximal dorsal to distal plantar, or from distal dorsal to proximal plantar. And then after typically what I do is I get the shift, I'll, hold it in place while, my assistant drives in the K-wire, or other way around, usually. And then after the screw's in and I find it to be stable, I will trim off that edge. You just got to make sure that, especially if your screw is kind of close to that edge over there, you don't shave off too much, because that can destabilize your osteotomy. And then if it becomes destabilized at that point, there's less of a ledge to kind of stabilize you. So you just got to be careful during that step. But yes, I'll start by shaving off the medial eminence. Then I'll do the chevron. I'll shift it over, and then I'll shave that leading edge after you shifted it over.
Okay. And I always read about the Aiken osteotomy. I guess number one, can you describe what the Aiken is, or the Aiken osteotomy is, and when you'd use it? And then the second part of that is, do you ever use it in cases where there's mild hallux valgus?
Yeah, so the Aiken osteotomy is basically a closing wedge osteotomy of the proximal phalanx. So this is basically referred to as kind of a cheater procedure, right? So classically, it's used for hallux valgus interphalangeus. So this is a separate from a bunion. It's basically increased deviation of the distal phalanx of the hallux relative to the proximal phalanx. Okay, so sometimes patients will have that in isolation, and then you'll do an isolated Aiken. But how I use it in the bunion is, sometimes you do your correction, you do your chevron or your more proximal procedure, and the toe is still kind of pointing in. An Aiken can often be very powerful in that case, just to kind of straighten out the toe and allow you to have kind of a more visibly satisfying correction. And usually this is stabilized with either a staple or usually a smaller 2-5 screw after you kind of perform this closing wedge osteotomy.
Okay, cool. So just to recap for those listening, for mild hallux valgus, IMA of less than 13, osteotomy that you can typically do to get a good amount of corrections. You can typically just do a distal osteotomy. You can do the chevron osteotomy, which if you think of it in your mind, it's like a V-shaped osteotomy with the V is actually distal, and then the limbs come proximally, aiming dorsally and plantarly, and you shift it laterally, you hold it in place with whatever fixation that you do, and you can use a saw to trim off the excess bone. And then you were also mentioned the Aiken osteotomy, which can be used in cases where there is hallux valgus interphalangeus, which is not the metatarsal, but actually the phalanx. And so that is mild hallux valgus. Now, what do you consider moderate hallux valgus? And then what would be your treatment for that?
Yeah, so moderate is basically, your intermetatarsal angle is going to get a little bit larger. All right. So typically, I think the book quoted as, anywhere between 13 and 16 degrees. These bunions look worse, again, both clinically and obviously radiographically as well. One thing I think I kind of didn't really gloss over or I kind of didn't really mention before was, because the sesamoids stay in place, one marker of how bad a bunion is radiographically is how uncovered the sesamoids are. So as that first metatarsal drifts over, that fibular sesamoid, which normally sits kind of right underneath the lateral aspect of the first metatarsal head, well, you start to see it appear in the web space. So usually in the more moderate cases, you're starting to see more uncoverage of the fibular sesamoid. You start to see it kind of at this, radiopaque structure in the web space. And this is often sometimes when patients see it, they'll be like, what's that? So that's another marker of a more moderate bunion, one that has increased IMA between 13 and 16 degrees, and also increased uncoverage of the fibular sesamoid.
Okay, cool. No, I appreciate you for explaining that part of it as well. So that's, definitely know about the sesamoids. Okay. And then so the osteotomy that you would do for the moderate hallux valgus, IMA between 13 and 16, what would you do for that?
So there are literally probably tens or maybe, ton of osteotomies. And as with everything, if there's a lot of answers for one particular thing, it kind of means that they're either all right or there's no one perfect answer. So,
okay,
you may hear the terms scarf osteotomy, malosteotomy, crescenteric, Ludloff. These all describes osteotomies that take place further back in the metatarsal and not just distally. And they all have their advantages and disadvantages, but the principle is the same. What you're doing is you're cutting the bone. One of them is the distal fragment, or what we call the capital fragment, and one is the more proximal one. Whatever cut you do, you're going to be shifting that more distal fragment or the capital fragment more laterally. And in the proximal osteotomies, you're pretty much not only translating, but you're rotating as well. And then you're stabilizing it. And that's the purpose of any proximal osteotomy, to realign the first metatarsal to be as parallel as possible to the second metatarsal.
So we spoke earlier about about possibly having some pronation of the hallux that you may see with hallux valgus. So when we're doing the proximal osteotomy, we're talking about rotating it. Are we trying to supinate it back to, I guess, neutral? Is that the rotation moment that we're looking for? And then for the distal fragment, we're bringing it a little lateral because it's deviated immediately because it's inverse.
Exactly. The so-called kind of triplanar deformity, which is the buzzword nowadays, but really something you have to keep in mind. So the distal osteotomies, like the chevron, the translational ones, you don't really have an ability to correct rotation, and usually you don't have to. The more mild cases, there's not as much of a pronation deformity. Once they get more severe, you have to account for that. So a lot of these osteotomies allow you to kind of rotate at the same time as correcting the varus deformity. And that's something you can judge by looking at your x-ray. You'll notice that if you just do it in one plane, the sesamoids might not perfectly line up or get recovered. And usually you have to add in a rotational component in order to get a full correction.
Well, I guess the rotation would also give you some planar flexion. So the one of the planes is going to be the lateral. There's going to be a distal fragment going lateral, and then I guess the other two planes would be more plantar flexion or of the distal fragment. And I'm trying to think what the other plane would be. I guess it's all rotation.
Rotational. Yeah.
Okay.
Yeah.
Okay. And we mentioned a little bit earlier, and I know you were saying it's controversial about the DMMA angle, that distal, I guess, metatarsal metaphyseal angle, which you kind of looking to see if the joint is congruent or not. Does that, I guess, what role is that supposed to play in this sense if you have a more somewhat severe hallux valgus where your IMA is between 13 and 16?
Yeah. Again, it's just the DMMA is something that's going to put you at a higher risk for recurrence if you don't get the joint congruent. So again, with a higher DMMA, they'll have a bunion, but their joint will look congruent. And if you just do a single osteotomy, what happens is you'll correct the metatarsal position, but actually you'll take a congruent joint and make it incongruent. And so after that, if left unrecognized, that can lead to a higher recurrence. And so, at least for the purposes of just a test question, I think if you see or it's mentioned that there's a higher DMMA, then the answer is always going to be a double osteotomy or biplanar osteotomy. You're going to cut it in two different planes or take out a small wedge medially in order to take a patient with a high DMMA and finish with a congruent corrected hallux valgus.
Okay. That makes a little bit more sense. And then I guess and then you mentioned the Mon Ludolf variations and there being multiple different proximal osteotomies that you can do, but you kind of mentioned the overall thought process of how to maneuver everything. But does anything change for your severe hallux valgus, and what do you consider a severe, bunion to be?
Yeah, so a severe one will typically be, something with a very high intermetatarsal angle. So something, generally around the 16 and greater category. Also, ones that are typically more severe are ones that demonstrate instability present at the TMT joint. And then how this manifests, at least radiographically, is, with weight bearing, they'll demonstrate plantar gapping. So you'll look at the first TMT joint, and it'll be gapped plantarly. This is like a pathognomonic sign for TMT joint instability. And basically, in patients that have this, along with a really high intermetatarsal angle, for me, the workhorse is going to be the Lapidus procedure, or a fusion of the first TMT joint.
Okay, and so. Does it matter? So if you have a patient that has like this TMT instability that but their IMA is like 12, do you still do a Lapidus, or do you and the Lapidus what you just mentioned is fusing the first TMT joint? Do you still do a Lapidus, or do you just do the distal osteotomy and get your correction there? Like, what do you like if the deformity is not as bad but they have this instability? What do you do?
Yeah, I'll still do the Lapidus. I mean, I'll explain to the patient that, again, once they demonstrate either clinically or radiographically that there's instability there, I tell them, even though it doesn't look so bad right now, the x-rays, and this may seem kind of extreme to do a fusion, it's actually the right procedure to do. Because again, these patients, especially if they're on the younger side, they will recur, if there's any instability present at the first TMT joint. So for me, clinical or radiographic instability at the first TMT joint, these patients will get a Lapidus.
Okay. And then you mentioned a little bit earlier that the higher IMAs, this is one where you have to do something proximally and distally in order to get that full correction. Does your plan change if there is any arthritis present in the first MTP joint?
Yeah, I mean, yes. So if there's arthritis and significant arthritis, then obviously, correcting a bunion is not going to address that. Okay, and I think it's important to note where their pain is. And so if the patient has pain at the first MTP joint, then along with associated arthritis, and sometimes these patients will also have a bunion as well. So that's why it's important to note where their pain is coming from. But in case of the patients that have all three, the correct answer is to do a fusion at the first MTP joint, or metatarsal phalangeal joint, which is highly effective at obviously getting rid of the arthritis and reducing their pain, but also allows you to kind of correct the deformity and get rid of the painful medial eminence as well.
Well, Dr. Tsai, I think this has been great. It's been super helpful for me, to learn this a little bit more. And I think the same with a lot of the listeners who will be listening to this. Is there anything else or any high points that you want the listeners, of this podcast or this episode to know about hallux valgus? Just anything at all?
No, I mean, I think we covered everything. I mean, I found hallux valgus to be a very enjoyable kind of topic to learn about, because everything just kind of made sense biomechanically, and sort of once you understand the pathoanatomy of hallux valgus, the surgery is just all sort of makes sense, and you kind of get why they work and sometimes why they don't work. So I think we did a good job of covering everything, involving hallux valgus.
Well, that's awesome. And at the end of our episodes, we always give away for our guests. If you have social media and you want the listeners to follow you or anything like that, feel free to mention it. And if you want to give any way to contact you, if not, that's completely fine. But we always just open the floor to you to let it be known if you have anything that you want them to follow you on.
Yeah, no, I don't haven't gotten into the social media yet, but if anyone ever has any clinical questions or questions about practice, they can reach out to me at my first name, my last name at rothmanortho.com.
Well, Dr. Tsai, again, I appreciate you so much for taking your time to come on this podcast. And, we hope that those that are listening, please go and leave a rating and leave a review and let us know how much you enjoyed this episode, and hit the subscribe button. And we will see you again next week for another episode.